We're going to talk today about the normal physiology of the heart. It's really important to know the normal physiology in order to understand the abnormal physiology or pathology. So, to begin, let's just look at a basic overview of the heart itself and start by talking about the anatomy of the heart. In all of these diagrams, oxygenated blood is going to be pictured as red, and blue will signify deoxygenated blood. This is really important because a lot of people assume that red means artery and blue means vein, but in the heart, there's going to be an exception to that, and I don't want you to confuse that. That's one of the really important aspects of the heart. So, that said, the entire right side of the heart is going to be blue because blood is coming from the body deoxygenated and being pushed out towards the lungs. On the other hand, the left side of the heart is going to be completely red because it's the opposite. The blood is coming from the lungs and going out towards the body, so that blood should be oxygenated. This is a better schematic of that, and so it's a really terrible drawing of a person, a really shoddy drawing of some lungs, but it gives you the general overview. If blood is moving through a vessel away from the heart, you call it an artery. If blood is moving through a vessel towards the heart, you call it a vein. That said, the pulmonary veins are going to be bringing oxygenated blood into the left atrium and then shooting it back out through the aorta to the body. On the opposite side, you have the pulmonary arteries pushing blood away from the heart that was brought back in through the inferior and superior vena cavas. That's a really important distinction to make because it's an easy mistake to make and it's an easy thing to fix. So, if we were to label all the components of the vasculature, we would have, as shown, the superior vena cava, the inferior vena cava coming into the right atrium, then to the right ventricle and going out through the pulmonary arteries. On the other side, we have blood moving in from the pulmonary veins, the right and left side, into the left atria, which then moves into the left ventricle and out through the aorta. The aorta has 3 different branches coming off of it from the ascending portion. So the ascending portion is the part going up from the heart right to the brachiocephalic artery, which is that first branch. The second branch is the left common carotid, and then the third branch is the left subclavian artery, and as soon as you pass that, you become the descending aorta. The whole thing is still considered an aorta, it just has different names depending on the part. You can also consider a thoracic aorta, abdominal aorta, and separate it based on where it is in the body. That said, the brachiocephalic artery also is going to have 2 different arches with your right common carotid and your right subclavian artery. That's why you only seem to have the left ones, it's just because they're not pictured in this image. You can review the vasculature on your own. There are plenty of good anatomy textbooks out there. As far as the valves and the chambers, there's going to be 4 heart valves and there's going to be 4 chambers. So we already talked about the right atrium and right ventricle and the left atrium and left ventricle, so that just leaves the valves. The atrioventricular valves are going to be the valves that are between the atrium and the ventricular. So there's 2 different sides. There is the tricuspid valve and the mitral valve or bicuspid valve. They are named as such because the tricuspid valve has 3 cusps and the bicuspid valve only has 2. Why it's also called the mitral valve, I don't know, but you're welcome to look that up and comment and let me know if you figure it out. You also have the pulmonic valve, which separates the right ventricle from the pulmonary arteries, and the left ventricle is separated from the aorta by the aortic valve. So they're all named appropriately. One little trick that can help you in order to remember whether tricuspid and bicuspid are on the left or the right, you can remember that you try before you buy. So if you're reading like a normal book and you're going from right to left, you try before you buy, meaning you have a tricuspid valve and then a bicuspid valve. So, we've talked about the anatomy, and now you're probably wondering, how does this all work? So, going back to that basic drawing, and we're going to kind of break it down piece by piece. There is some important vocab that you should know before we begin, and that is systolic pressure is going to be anytime the ventricles are contracting. Diastolic pressure is going to be when the ventricles are relaxed during diastole. There is also a value called the mean arterial pressure. This is an average of the pressure that's in the body in both systole and diastole combined. And there's a formula in order to calculate that, and it's 2 times the diastolic plus systolic divided by 3. So 2 separate values combined together gives you your map. These normal values should range from either 70 to 110. If they're less than 60, it means that they're not going to be able to perfuse very important parts of the body, including the coronary arteries, the brain, and the kidneys. So that 60 is that magic number to be able to perfuse your body, but that said, 70 is where you hit normal. Mean arterial pressure can also be calculated by combining the cardiac output and the total peripheral resistance. Cardiac output is going to be the volume of blood that's pumped per minute, which includes heart rate and stroke volume. Stroke volume is the amount of blood that's pumped out in each heartbeat. So if you take cardiac output, meaning the heart rate times the stroke volume, you can substitute that into your MAP formula and get heart rate times stroke volume times the total peripheral resistance is equal to your mean arterial pressure. Another important vocab set is going to be your contraction stimuli and how the heart gets its signals in order to contract. So there are 2 different basic types of stimuli which cause the heart rate to adjust in order to change how much blood is getting out to the body. Chronotropic control is going to be your beta receptors. These will be on the sympathetic nervous system, and then they affect the SA node. And the vagus nerve will respond to acetylcholine, and this is your parasympathetic nervous system. Baroreceptors are going to be in the aortic arch, the carotids, the arterioles supplying the kidneys, the atria, and the pulmonary arteries. And baroreceptors are basically stretch receptors. These send signals to the cardiovascular center in the brain, which is basically the lower medulla and the pons, which tells the autonomic nervous system that it needs to adjust peripheral resistance based on how stretched out the actual vessels are. So now we can talk about how the heart actually pumps. And we'll talk about diastole first because the S1 sound is going to be the sound of your AV valves shutting. And so for me, it makes the most sense to start with diastole because then you immediately start with that S1 sound. So diastole has passive filling of the atria first. So both the right and left atria get filled with blood. The right atria, it comes from the superior vena cava and the inferior vena cava, as well as the coronary veins. And the left side of the heart, it's coming from the pulmonary veins. So, like I said before, the right atria blood is going to be deoxygenated, and the left atrium blood is going to be oxygenated. Now the SA node is going to stimulate the atrial myocytes to contract. This is going to squeeze the aorta, which will force the pressure to be way increased on that side, and it will be lower in the ventricles. This pressure difference between the atria and the ventricles is the reason that the blood is going to flow from the atria into the ventricle. So on both sides, the blood will flow through the AV valve into the ventricle. Once the pressure is equal on both sides, your AV valve will slam shut, and that is your S1 sound, aka your lub. Once those valves are closed, the blood volume in the ventricle will be called the end diastolic volume or preload. So this is the amount of blood that's in the ventricles prior to being squeezed out into the body. Now systole begins. So systole is the time between S1 and S2, and it includes the ventricular contraction. So deoxygenated blood is going to move into the lungs from the pulmonary arteries from that right ventricle, and on the left side, blood is going to move over that aortic valve out through the aorta to the body, through the brachiocephalic vein to the right side of the body, and through the left common carotid, left subclavian to the left side of the body, and down through the descending aorta to get to the lower extremities and trunk. Once the pressure is equal between the ventricles and both the pulmonary arteries as well as the aorta, that semilunar valve, as far as pulmonic and aortic valves, those are going to slam shut in the same manner, but that's going to be a more forceful slam, causing your second heart sound, which is your dub. So you have your lub dub, lub dub, lub dub, and it's basically diastole S1, systole S2, diastole S1, systole S2. If you know the normal physiology of the heart, understanding murmurs and why they occur and when they occur becomes a lot easier. So we're going to have the next video most likely cover murmurs and extra heart sounds, because I think that makes the most sense to move to from here. As far as the electrical system of the heart, I'm going to cover that in a video in which I go over kind of different arrhythmias, because that's kind of a quick topic, but it makes more sense to go over that while we go over what can go wrong with it. So that will be one of the upcoming videos as well. Those are the things that I anticipate starting with. Thanks so much for watching, and we'll see you all in the next video.